Okay, first things first, good morning. Welcome to the Comprehensive Tactical Athlete System Education Clinic. Today, we're going to be talking about mobility improvement, which was a request from one of our CTAS members. This discussion, this lesson, are going to get into the two programs that you see on screen, which is HPYP and PRTP. That being our reconditioning program, and then of course our program based on increasing an individual's both awareness and capabilities with regards to physical training. Now, to get started, I always like to start with some critical thinking questions just to kind of get the mind in the same realm of the content we're about to discuss. So, Sergeant Watts, if you may, what would you describe, or rather, how would you describe your understanding of mobility?
I would describe it as pretty much being able to move efficiently, like bending, bending, hinging, squatting, just having full range of motion.
Okay. So you mentioned efficiently, you mentioned certain biomechanical patterns, right, such as squatting and hinging, and then range of motion. And you're right in the sense that all of these can be comprised of mobility, or rather, mobility can supplement each of these other variables. Now, generally, the way mobility is defined is the functional range of motion, and even functional somewhat has a vague description, right? So you could be functionally strong. You can talk about functionality with endurance, with stamina, and then range of motion, of course, is the degree to which you can manipulate a joint and the surrounding muscular structures for the joint. Good morning, Sergeant Delagarza. So for mobility, when we're talking about this on the physicality point, there are a lot of different pieces actually can come into what makes someone mobile, how they are mobile, and then of course, do we need to address mobility at all? But before we get into those variables, Sergeant Delgaja, what would you think would be the opposite of mobility when we're talking about physical performance?
The lack of, let's say, for example, lack of solar actually being agile, non-agile,
Okay.
So, maybe not a fast runner, or not someone that has lots of movements.
Okay, someone that may be restricted in some of the movements. What do you think, Sergeant Watts? What would you say would be the opposite of mobility?
Being stiff, having imbalances with certain movement.
Okay, so being stiff. Interesting. So both of you have somewhat of the component of what I'm looking for. The way I want to address this is mobility isn't necessarily a positive variable. Right? When we're looking at this as a leader and as a trainer perspective, we generally talk about wanting to be more mobile, but that may not always be the case. Sometimes an individual can have too much mobility. Sometimes individuals can have too much stability, which would be the physiological opposite of mobility. Right, so we're going to talk about in this block of instruction, we're going to get deeper into the differences of those definitions between mobility and stability. We're going to use that to talk about the athletic joints. There are myriad joints within the body, but from our perspective, not necessarily being a physical therapist or an anatomist, we need to be able to talk about what is practical for us and our soldiers to be able to manipulate. We're going to revisit fascial pathways, which we introduced in the physiology class, and compounding the knowledge we're going to be talking about with the aspect of athletic joints. And then, of course, we'll time permitting, we'll do some form of a practical exercise here on mobility. I'm also going to start introducing what we're going to be using on the information side today for mobility improvement the next time we do a physical class, and especially for our next assessment, when we start getting into our warm-up phase, and just kind of a, not necessarily like a check on learning, but pulling back from prior knowledge, which of the three primary warm-ups would you say really involves mobilization?
I would say the dynamic warm up.
Perfect. Perfect. So remember, there's 3 types of warm-ups. You have a general warm-up, which focuses on the cardiovascular system, right? Increasing the responsiveness of your nervous system, your heart rate, and your body temperature. You have your dynamic warm-up, which is largely movement and joint focused, where you're either trying to mobilize or stabilize a certain structure in order to both mitigate injury and enhance performance. And then the specific warm-up, which potentiates the exercise. In other words, it primes it. You're doing the same exact movement pattern as your main activity, just at a lower intensity. So good. So let's get into these pieces. So mobility versus stability. These are things that this is how I would recommend, rather, for you to consider this from a coach's perspective, a trainer perspective, or just as a leader's perspective, because even when we're not talking about improving physical fitness or an actual physical activity, these variables for mobilization and stabilization are present in everything we do in our day-to-day lives. This could be you reaching into the fridge, right? Maybe something is at a lower shelf in the fridge. And due to obviously you having a physical structure in front of you, how does that individual manipulate their body in order to get that item at the bottom and back of a fridge? Maybe this is reaching into a crib for their infant, or picking up after their dog. Whatever this may be, you could be in a warehouse doing cyclical inventory, right? And trying to reach and move around boxes in connexes, ISU 90s, etc. We need to be cognizant of how our bodies move and how aware our soldiers are of their bodies moving. So when we're looking at mobility and stability, we need to look at this as what movement pattern is being performed, which was aforementioned by Sergeant Watts, right? Squatting, hinging, lunging, pushing, pulling, climbing, all of the primary physiological movements that every exercise is basically broken down into. When we look at that movement pattern, we need to think, what is the minimal amount of range of motion that may be required for this activity? What type of population do you think understanding the minimum requirement of range of motion would be most prevalent for?
General.
So what do you mean by general?
You're talking about the exercises before.
No, so let me rephrase this. If you were with your soldiers and you already had an exercise or a training program planned, and you were getting ready to conduct these movements, not talking about the warm-up phase or main activity, which population amongst your soldiers might you be most concerned with their ability to hit the minimum range of motion?
Oh, or like the overweight.
Perfect, perfect. Were you able to hear that, Sergeant Watts?
No, I didn't hear what he said.
Okay. So, want to say that again, Sergeant De La Garza?
Just the overweight population and the ones that are in temporary profile.
Excellent, excellent. So for our special population, which for us would be pregnancy and postpartum, those that are overweight or obese, right? Those enrolled in the Army Body Composition Program, as well as those that are either failing to meet the unit-based physical readiness training program standards, because every unit will have its own requirements with regards to the movement patterns that are more essential for them, right? My armors are going to have a different biomechanical demand than my quartermasters, right? And even amongst quartermasters, your petroleum supply specialist may have a different requirement than your laundry and bath specialist, right? Things of that nature. So, and of course, those on temporary or permanent profile. So those that have some type of musculoskeletal injury or limitation that you are hopefully aware of as either the first line leader or the master fitness trainer or H2F personnel with regards to CTAS. Those are the ones where we need to know what is the minimum required range of motion that you need to be able to effectively perform this exercise. Because if they can't do it, then perhaps we need to choose an entirely different exercise that can try and match as close as possible or supplement as close as possible that biological or that biomechanical demand. Optimal would be your general population, right? What range of motion do you want them to be able to get into? If it's a squat and a deadlift, a bench, picking a box up, carrying a water jug, like how should their athletic joints be moving through the exact plane of motion that you want it to be moving through? And then maximal range of motion is a preventative measure, similar to when we talk about minimum range of motion with a special population. For every exercise you choose, and when you're thinking about whether you need to mobilize or stabilize a joint, we need to be considering what is the maximal range of motion we would want to see in order to help try and prevent injury. Can either of you kind of hazard a guess if I limit it to the ACFT, which movement pattern in the ACFT may have a maximal range of motion concern with regards to mobilization or stabilization?
Sprint track carry.
So Sergeant De La Garza says sprint dry carry. What do you think, Sean Watts?
I would go with the deadlift.
Sorry, say that one more time.
The deadlift.
The deadlift.
Yeah.
Good. So it's relevant in every exercise. So I'm not going to say necessarily right or wrong. What I'm looking for more than those would be the standing power throw. And the reason I say that is the standing power throw is an open chain exercise in which you have to worry about acceleration and deceleration of forces, more so the latter than the former. If you think of a pitcher or a quarterback throwing, the time where the individual, the athlete, is the highest risk of injury is the deceleration of force. Right? Your muscles are able to create a tremendous amount of force, which will, in this case, we're putting that force into some type of external object through increasing velocity. And when we do that, we have to slow down our joints against gravity and at that in range of motion to be able to hopefully pull back without injuring ourselves. And if you want to perform well in the the standing power throw, you need to be able to explosively throw this 10-pound sphere as far behind you as possible, which is not necessarily a pattern that most people are accustomed to. It's a very atypical thing for us to do if someone doesn't train for it, even though it does have a high carryover for different aspects of our population. It's worrisome from a trainer perspective if you have an individual that never touches this weight, even if it is light, trying to go through this deceleration of force. If you notice, therefore, when watching an individual perform this exercise, or in a safer manner, choosing warm-ups such as a kettlebell swing or a front raise in order to be able to see how they move, and you see that their shoulder mobility and their scapular mobility is too mobile, or otherwise described as hypermobile, then what do you think we would need to focus on in a warm-up prior to actually having them throw a ball?
Power, the strength.
Maybe not so much. What do you think, Sergeant Watts?
I'm sorry, can you repeat that question, Cyrus?
Absolutely. So if we were in a gym or out in the track and we were training our soldier specifically for the standing power throw, per our prior discussion with its open kinetic chain and the power involved, we noticed that at the shoulder joint or at the scapular, in the scapular area, when the individual goes through maybe a kettlebell swing or goes through a forward raise into an overhead position, that they are too mobile or hypermobile at those joints. What would we therefore need to do in that soldier's programming to help prevent injury and increase performance?
We probably might need to fine tune like their mechanics, because like you said, if they're too mobile, then they need to find what point in their range of motion that they don't need to go past to prevent injury.
Good. So we need to see where that maximal range of motion is if they're hypermobile, and then we would need to train stability within that joint. So if someone is hypermobile at a joint, our main focus, once we've made that observation through some form of a needs analysis, is to focus on stabilizing that joint, or rather teaching that individual how to stabilize in motion, because of course, most things that we do are within motion. They're not necessarily some static aspect or a non-moving aspect as you would have with like a strength training machine or a closed kinetic chain exercise in a gym. When we're out and we're actually walking, we're patrolling, we're holding our weapon, we're clearing an obstacle, what have you, we are going through these movements where our joint can exceed our optimal range of motion. And when that happens, we're at a greater risk of injury. So once we've observed that either we or our athlete, our soldier is hypermobile at a joint, our primary thing for that joint, for that main activity that it's involved with, is to stabilize that joint in motion. On the reverse side of it is what we're normally used to, which is someone being hypomobile. In other words, they lack the proper mobility to get to a functional range of motion. And that's when we want to actually mobilize that joint within that warm-up, be able to increase the range of motion it's able to go through, especially at intensity, in order to be able to increase performance. And the increase of that range of motion is typically what we see within that dynamic warm-up, whether that's preparation drill or whether that's you in the gym doing some type of hip or scapular-based movement in order to make sure you can increase, the neuromuscular activity and the blood to the area for more motion. Good morning, Sergeant Latney. Any questions so far on mobility versus stability for the variables that we've discussed?
So you would say like just doing like a preparation drill that for the shoulder, you know how you were talking about the shoulder blade?
Yeah.
Like just doing like some
arm circles?
circles, yeah, like that will help them out like with stability.
No, that's a very good question, right? So when you go in and around installations or unit formations conducting physical training, you see a lot of outdated practices and a lot of things that are well intended but may not have good evidence behind it. So arm circles are a good example. Flutter kicks are another good example. Things of that nature where someone will look at the joint and think, I'm going to work shoulders, so let me do something that involves my shoulders. What's lacking there is the specificity for the soldier on what would actually be good for them, especially whenever we're training a group versus training an individual. There's that fall off of something being useful for that soldier. In some cases, it could actually be more harmful to the soldier if they're not aware of what they need prior to performing. So when you're doing a shoulder circle, you're kind of going through, you're not going through rotation in the humeral joint whatsoever. Your humerus isn't internally or externally rotating within the actual shoulder girdle. You're going through a slight amount of flexion if you're going, you're doing the circles rearward, or you're going through extension if you're doing those circles forward at a very, very slight amount. So you're getting blood throughout various heads of your deltoid to stabilize the movement. But other than that, you're not really mobilizing the joint too much because you're not going through full optimal range of motion in a pattern that you would otherwise do or perform, right? And you have to think, at what point in time would I, in this activity, need my soldiers to be at 90-degree or horizontal adduction with their shoulder joint and be able to maintain that? There is a sport and a specific movement within a sport where that's absolutely relevant. Can you think of what that would be?
Baseball?
Not discus. Where in baseball would they need to maintain bilateral horizontal adduction at the shoulder?
I think it'll be probably somewhere of the swing of the bat. So it's like that.
All over the catcher.
No, now you're using the shoulder and you're getting a little bit closer, but you have a hazard to guess there, Sergeant Watts? Bilateral horizontal adduction at the shoulder joint in the sport.
You said which sport?
Mm-hmm. Your arms out to the side.
I'm not sure.
All right, so it would be gymnastics and the iron cross. In the iron cross, you're specifically holding a static position with horizontal adduction at 90 degrees in order, well, give or take 90 degrees, in order to keep the body in that position. So arm circles prior to would be very relevant, at least to be able to manage the specific neurological pattern of having those arms in that position. Does that make sense? So we always need to correlate what we're doing. If we're going to be having someone going through a standing power throw for the ACFT, we know they're going through shoulder flexion from potentially 180 degrees if they start directly below the legs, maybe a little bit past that if they're starting behind them in order to get good momentum through the hip hinge motion. And then they're going to be coming past, they're going over at least 180 degrees of motion because their hands are going to have to pass their head in order to apply force into that ball and have enough velocity for a good angular curve to try and get that parabolic curve for an optimal throw. So when we do that, if we notice, and I'll mention this if you are unaware, as you're going through shoulder flexion with your hands in a neutral position, right, which means your palms are facing each other, some of the most common deficiencies observed in that biomechanical pattern for the throw is that once the arm starts approaching the head, once it starts getting to 90 degrees, you start to see a compensation of external rotation of the humerus because they lack typically stability or mobility in that movement, depending on how and when it's observed. So they're lacking optimal position in that movement, which causes flexion of the elbow. And that flexion of the elbow shortens their lever that they're throwing with, kind of like adding an extra joint in a catapult. And that makes the ball have a quicker fall angle, so it's going to go down quicker instead of going further, which is what you want. Right, so you want your arms to never have any type of flexion within the elbow joint during that throw, which means the stability and the motion has to come through that scapula, through the shoulder joint as you're going through that hip hinge motion.
So like a warm-up or a proper warm-up practice, that would be like a bend and reach.
So a bend and reach would be a good dynamic warm-up to be able to and bend and reach focuses primarily on your vertebra in order to take your spine through flexion in a controlled, non-ballistic manner, right? Get the spinal fluid moving. So that'd be good to practice the slow, controlled patterning of going through spinal flexion, but then you would adapt that into your specific warm-up with a Russian kettlebell swing and then an American kettlebell swing, right? Being the what's initiating the movement, and then the height that you're moving to being parallel to the ground and then overhead, respectively, for those two swings. And then as well as potentially doing a plate front raise and getting into heavier intensities, watching the shoulder joint and getting the soldier to understand, not just to do it, but to understand that they need to keep their shoulder from externally rotating through the motion. And once they understand that, then it requires practice and repetition into that physiological pattern has been, established. Good. Right. So that's an example of looking at the movement pattern to be performed and looking at their optimal functional range of motion. You may have an issue where a soldier has prior shoulder impingement for this particular example that we've been talking about, in which they can go through shoulder flexion up and near 90 degrees, but past that, they start to feel some potential restriction, discomfort, or pain anteriorly on their shoulder socket when they start to get above 90. And if you're seeing this in the gym, if you can then externally rotate the shoulder a little bit earlier and go through the motion and they find that they're without restriction, that means they need to work on mobilization of that joint at that angle. And that may take some time to slowly get more and more and more range of motion, whether using resistance bands, cables, free weights by putting the body against gravity, maybe in an incline or decline position, whether pronated or supinated, and going through something like the shoulder stability drill, in which they can practice that functional range of motion to get the body to stop overreacting to cause that pain. Good. Questions so far? All right, so when we're looking at that, we have to look at the range of motion as we've been discussing. We also look at the modality that's going to be used, whether that's a barbell, dumbbell, kettlebell, suspension trainer, like a TRX, medicine ball, what have you. Because the barbell, or let me ask this, what is the primary difference with regards to utilizing a barbell for a movement like an overhead press or a bench press versus a dumbbell to do a shoulder press or chest press, respectively?
Like the difference in your body or?
Sure.
I guess it's just I feel like it's the control.
Okay.
So it's like, it's the strength. I always look at it, the strength of them. So one's equal out weighs more. So like I say, if I were to do a bench press, and I try to use the I guess the barbell for like if I'm going high or weight or whatever. But as far as I'm trying to keep the same strength or even the strength out, I'll do the dumbbell because you can see
any type of potential discrepancy. Good. What were you saying, Sergeant De La Garza?
No, I was just mentioning stability, like the difference between them because one is a full bar, like you're trying to balance it, like with your forearms, and you're using more of your forearms and biceps.
Okay. Good. Anything to add to that, Sergeant Watts?
No, it's all right.
All right, so you're all right with regards to some of the key differences. So with a barbell, most movements are bilateral, and a barbell is ergonomically designed in order to make it easier to move for the primary movements that you're going to be doing in order for you to get the most out of it. Because it's not as challenging to do each of your core lifts, you're able to get a lot more force into the movement, meaning you're able to add a lot more load on the bar, right? A lot more external resistance, which means your muscles have to produce more force, meaning that you go through more bone remodeling, and you're actually innervating much more of your biological systems, which means you have a better adaptation. Whereas when you have a dumbbell, as is mentioned, it creates a more unstable motion because now you have to use a lot more stabilizers, right? In the case of a dumbbell chest press versus a barbell bench press, there's a lot more individual wrist stabilization that has to come into play, which was something that may fatigue your forearms, as an example, or your serratus anterior, your intercostals, right? Something that may have to prevent the anti-rotation that's happening unilaterally across your body from one shoulder to the other. And as Sergeant Latney mentioned, this may be a good assessment, an active assessment during the activity to see, do you have any unilateral deficiencies, right? Are you initiating a press more with your left side versus your right side, right? Is your left elbow going to extension before your right elbow? Are they evenly distributed? Are both kind of along the line of your sternum or in the same line of your pectoralis major, or is one closer to your shoulder and one's actually closer to your sternum, right? So you could be aware of these deficiencies to see, do you have stability or too much mobility rather within these actions. And that's one of the things that makes something like a dumbbell, kettlebell, or suspension trainer more difficult, and why it's good to be able to add variety with these modalities when we need to introduce something. So sometimes if we need to make sure we can make the shoulder joint more stable, the utilization of a unilateral modality could be very useful, or it could be beneficial to the overall adaptation. I will take this time to say that just changing up the modality doesn't solve the problem. If your athlete isn't aware of what they're doing, if you're not helping increase their physical literacy, which is the bullet you see on the bottom of the page, if you don't teach them as a trainer and a coach what they are doing, they may have some adaptation just through the repetition and the consistency of the action, but it's going to be extremely limited because they are not, cognitively going through that pattern in the way that you want them to go through. Which is where external and internal cues as a trainer, as a coach, become extremely beneficial. Something that's a quick phrase that you've already discussed with your athlete that they should understand what that quick phrase means, right? So if I want someone to separate the earth for a deadlift or a squat, I need to teach them what separating the earth means, right? And that conversation would be, I want them to, externally rotate or act like they're trying to externally rotate at the femur with their feet firmly planted in the ground to be able to create that angular torque. So they provide more force in the ground, so it provides them more stability throughout those motions. And there's a lot of things that go into that, but I can't say that during the active exercise that they're doing. I just need to teach them that so I can give them a cue of separate the earth. Good. And then the speed of the movement is very important. When you add velocity, a lot more velocity to a motion, especially if it's a continuous motion, which then you have to either counter or deal with momentum, that completely changes how mobility and stability come in. We are absolutely more mobile through a dynamic motion and a quick motion than we are through a slow motion. The easiest way to assess this on yourself, just for understanding, is if you stood up and you try to slowly bring your leg as high as you can bring it, right? For you, if you're going to try and bring your leg 90 degrees minimum for you to touch your toes. A lot of people cannot slowly bring their hip through flexion to get to a point where they could touch their toes without an extreme amount of knee flexion and no flexion of the spine. But if you quickly kick your leg up, you can almost easily touch your toes because we are more mobile dynamically, right, through the amount of force that's produced. So that basic concept of physiology is crucial to understand when we're looking at the speed of a movement someone's going to have to be able to perform. If someone's jumping over an object or they're landing, the eccentric force of a plyometric exercise, or at least a lower body, jump, whether they're jumping out of a vehicle or off of a pull-up bar or whatever it is, they're going to be more mobile at the hips, the knees, the ankles, the subtalar joint. However, if we can't get them into that range of motion slowly, and we can't get them under that range of motion with control, then when they do get to that excess range of motion and their body doesn't know how to handle it, that's when we have an overreaction over a compensation of a contraction, like your muscle spindle sees you're at too long of a range of motion. If you remember our proprioceptors from the physiology class, it causes a concentric contraction at associated muscles, and that concentric contraction typically leads to an individual feeling that they've pulled a muscle or injured a muscle. That's really what happens when someone has a lateral ankle sprain, right? So a lateral ankle sprain comes from plantar flexion and inversion of the ankle and subtalar joint respectively. And if an individual doesn't have the mobility to really get to that position, the quick compensation that happens from that is where the injury occurs at the associated ligaments. And then that can take a while to heal, because once you've kind of damaged that proprioception and you've introduced inflammation in the area, your body's first thing to do is to restrict range of motion. Now that restricted range of motion has a carryover because every time you go outside of it, your body has a safety effect, and it's almost like you're re-injuring it. Right? So things like that. This comes into the. You seeing how this ties into the overall concept of mobility and stability?
Right.
Good. So that ties into environmental considerations, such as even and uneven terrain, especially when we talk about that lateral ankle sprains. Right? If you're going to be running on a beach versus running on a track, completely different way you're going to train your stabilizers. Your soleus is going to be hyper utilized, so your peroneal, so you may feel a lot more of the arch of your foot, and the dorsal aspect of your foot right at your ankle joint being a lot more sensitive, and a lot more delayed onset muscle soreness the next day. If you're working on more frictionless surfaces, such as a basketball court, wet grass, ice, then how your stabilizers have to work in order to keep your tibia from moving too far, so especially with your knee joint, which is where a lot of ACL and MCL tears come from, then the knee joint internally or externally rotating when it's in flexion, right? You need to be aware of the risks of the surfaces that your soldiers may be operating on. And then therefore, if you know you're going to be operating on wet grass, what do you need to do in training? Work on wet grass. Yeah, not a trick question. We need to ensure whatever environment where our soldiers are going to be operating in, and under whatever constraints, we try and replicate that in whatever safe manner we can for their overall awareness of repetition through training. What tends to happen from a leadership perspective is we see some of these risks and we try and mitigate them maybe a little bit too much, and when we're kind of risk adverse. And when we do that, we may be increasing the risk at the actual activity itself, because now we haven't trained the body to be able to do what it needs to do. Good. Prior injuries is another one, similar to, again, when we talked about the lateral ankle sprains. One of the first things your body loses is proprioception, which affects your body's awareness of lengthening or the length of a muscle, because your muscle spindle measures or constantly rather sends and receives a signal of how short and how long every muscle structure is. And then your Golgi tendon organ, your GTO, measures the amount of tension going through the tendon, which is what connects your muscle to your bone. And both of them have safety features that will either allow or not allow you to produce force optimally based on past experiences. This is also why strength training is so important, because as you constantly introduce high intensity activities, right, that sub 5 repetition range, the body gets used to the load tolerance of force being produced at the joint, so it stops governing your force production, so you can actually go through more range of motion with higher intensities. But if you don't train there, then your body will always keep you from training there. All right, any questions on topics for this slide? All right, good. So with all that said, now let's get into what the athletic joints are. I'm going to spend a little bit of time on these because it's important, but these clinics aren't the time to try and memorize your anatomy and physiology. I don't expect at any point in time any of our leaders or our CTAS members to know every muscle or bone in the body. I'll tell you, I certainly don't. I have an extensive knowledge with anatomy and physiology because I've taught it for a decade, but even with that, there's certain things that just don't tie into the scope of practice that we will be operating with. However, knowing the athletic joints at a minimum are extremely important. Now, every single one of our athletic joints can go through between 2 and 6 joint actions. Why do you think there's between 2 and 6 joint actions? What do you think those relate to? You're right, direction. In what way?
Like as far as in lateral to something, up, down.
Perfect. You're exactly right. So what do we call that with regards to biomechanics? If something can only perform 2 joint actions, it can only move in one what? You got it, Sergeant Watts?
No, I don't.
Okay, so if something can only perform 2 joint actions, that joint can only move in one plane of motion. If it can do 4 joint actions, it can move in 2 planes of motion. And then of course, there's only 3 planes of motion. So the maximum joint actions a joint can perform are 6, right? And there's always the antagonist agonist motion, right? The primary movers moving in a certain plane of motion that you want it to do, and the antagonist supporting through reciprocal inhibition. So if we look at our ankle joint only goes through plantar flexion and dorsiflexion. It's the only thing it does, and that only happens in the sagittal plane. So regardless of whether you're on your back, on your stomach, crouched, you have your legs facing in, facing out, it doesn't matter what position you're in, that ankle is always moving through the sagittal plane. Through plantar flexion, which is pointing your toes down, which happens through your posterior lower leg. So your calf group, right? Your medial and lateral gastroc, your soleus, etc. And then dorsiflexion, which is you pointing your top of your foot toward your shin, such as what happens in the bottom of a squat. So if we notice that if someone's going through a squat and they typically end up having their calcaneus, their heel come up, and then they compensate. Good, Sergeant Latney. They compensate through a forward lean because they potentially lack dorsiflexion. Then a common intervention would be to either put them in higher heels, such as a lifting shoe, or putting plates underneath their calcaneus in order to limit the amount of dorsiflexion they have to go through and improve their capabilities. Simultaneously, that should tell you that in the warm-up, what should you focus on?
I would say that range of motion, the dorsiflexion on cylinder.
Good. So what that means is, and this is a good example of an exercise, Sergeant De La Garza, but for the terminology that we're discussing for this particular clinic, if they are lacking range of motion through dorsiflexion, that means that that ankle in dorsiflexion is too what?
If they're lacking it. So, yeah, so basically, I mean, it's limited to a certain extent, so I guess.
Right.
I guess the stability or the.
Perfect. You got it. Actually, sorry, Lenny, can I have you sit over here? That way I make sure the microphone can pick you up better as well. So if they're lacking dorsiflexion, that means they're too stable in the sagittal plane at their ankle joint, or at least through dorsiflexion, meaning that you have two possible options to test if you can increase the range of motion as an athlete, as a trainer. So the moment you notice that in the squat, that means that either right then and there or in the cool down, somewhere within that session or the next session, you need to assess that person's range of motion through dorsiflexion. That can be done unilaterally through a lunge, or that can be done bilaterally through a squat. See how low they can go before they start losing dorsiflexion. As an example, an easy way to do this is you can take a PT belt, you could put it underneath their calcaneus, and have them go through dorsiflexion with a constant pull. You're constantly pulling the PT belt, and the moment that that PT belt comes out, even if you don't visually see a difference, that's their current range of motion with dorsiflexion. So what you can do is you can either mobilize the ankle joint by taking it through more dorsiflexion with a bend or with some other type of resistance in order to help inhibit the calf group from being too active, since the calf group goes through plantar flexion. Or you can try and stabilize their ankle joint in plantar flexion to try and reciprocally inhibit that to allow them to go through dorsiflexion more. But this is one of the beautiful things in my opinion with regards to understanding anatomy there's a lot of variables that are involved, but once you start breaking it down into compartments, almost everything comes down to 50-50 within exercise science. So once you really fine tune it, it's either this or it's that. It's this or it's that. You can, and once you start limiting things, you automatically know what it's going to be. Right. So I'm using that one example to talk about the same thing that doesn't relate to everything else. Right. So for the subtalar joint, those movements are eversion and inversion. The easiest way to remember that is inversion, or when the soles of your feet are facing inward, they're facing each other. That's also called supination if it's in motion. If it's an eversion, it's called pronation if it's in motion. All right, so if you think of you holding a bowl of soup with your feet, right? If you're holding a bowl of soup with your feet, you're inverted or supinated. It's not spelled the same way, but it's supinated. And then eversion would be the opposite. You're going to have a lot more range of motion through inversion than eversion because of your tibia and your fibula. You see it sit there, right? The medial or inside ankle bone is your medial malleolus. That's the sort of bottom of your fibula. And then the tibia is the lateral malleolus, the bottom insertion point for most of your ligaments and your tendons. Okay. So that covers the foot. And then when we move superiorly or up the body, we get to the knee joint. Now, the knee joint really only works through the sagittal plane, which is flexion and extension. However, if your knee is flexed, you do have the capabilities you can see me doing here of slightly in. You're not moving your ankle though. You're moving the tibia, right? Where you can go through slight internal and external rotation, but you can't do that when your knee's extended. If you extend your knee and you do the motion, that external and internal rotation comes from the hip. When you flex your knee, it comes from the tibia. Now, that slight amount of internal external rotation is important because of how we are bipedal, but that also introduces a huge risk of injury. If you look at this in a squat or a deadlift pattern, when you see someone either go through the eccentric portion, which is the downward motion, with the concentric portion, which is the upward motion of either of those exercises, and the knees cave in due to instability or hypermobility, then that is called a valgus or a valgus collapse, meaning they couldn't maintain, yes, the buckling, exactly. They couldn't maintain stability with that degree of force through that range of motion with that modality, and they compensated through internal rotation of the femur and internal rotation typically of the tibia. This is where this puts an extremely high amount of force on the ACL, LCL, and PCL. And just generally where we see these injuries happen on on the field, right? So if you watch football, when the knee, or even soccer, when the knee is flexed and then it's pushed immediately, it's pushed inward, that interrotation that happens puts too much pressure on those ligaments, and then you typically get some type of
hyperextension, right?
It is, exactly. Then you'll get a grade 1, 2, or 3 tear, right, of the ligament. So it is possible for the knee to go through internal external rotation, but it's never a goal. We always want to make sure the knee is a stable joint rather than a mobile joint. The only time we want to work on mobility of the knee joint is post-op. So post-operational surgery for one of the ligaments within the patellofemoral joint. And usually that's a limitation of flexion that occurs because your quadricep group turns into your patellofemoral tendon and connects to your tibiotuberosity, your tibia on the other side. And so they'll lack the ability to go through full extension of the knee. So then that's when you get on like a knee extension machine, a leg extension machine, and you work on the functional range of motion until you can get to full extension, right? But outside of that, we always want to focus on stabilizing the knee through movement, whether that's through a step up, which would be a unilateral stabilization, such as in a lunge, or a bilateral stabilization, which would be like a jumping and a landing, even though you can do jumping and landing unilaterally as well, or through a squat and a deadlift. Questions from you, Sergeant Watts, or anyone in the room with regards to this slide?
All good, sound right?
Perfect. All right. So the next would be the hip joint. So how many joint actions do you see here for the hip joint? What's the maximum it can have? 6. Good. Which means the hip goes through how many planes of motion? 3. That's the maximal. That's all it can do. The hips are your second most mobile athletic joint in your body. They can go through every single plane of motion, right? Sagittally through flexion. And here's another piece for the 50-50. If you are talking about the sagittal plane of motion, the only 2 joint actions that happen in the sagittal plane are flexion and extension, period. So if a joint can go through flexion and extension, you know it's happening in the sagittal plane. There is no exception to that. That's absolute. The frontal plane are our lateral based movements. What 2 joint actions happen in the frontal plane? Those are right up there.
Adduction and abduction.
Good. Abduction and adduction. Right. So whenever you're talking about moving through the frontal plane or laterally, the only 2 things that can happen in that plane are abduction and adduction. The easiest way to remember that is when you're adding a limb back to your body, right? So if your arm is up and you're bringing it down to your side, your leg is out, you're bringing it in back to your body, that's adduction. You're adding it to your body. If you only remember that, you'll know the other one, right? So you only really need to know 50%, right? So adduction happens in the frontal plane. A lot of times people don't train specifically in the frontal plane. And we talked about this in the injury class. Your frontal plane stabilizers are typically what allow you to produce force optimally in the sagittal plane. Because if you lack stability or mobility in the musculature of that's involved with particular abduction, adduction, which generally happen at the hip and the shoulder, although they do happen otherwise, then you lack the ability to functionally move in the sagittal plane. Right? This, and then internal and external rotation are the transverse planes of motion. So whenever we're looking at movement, we want to see where restrictions are at certain ranges of motion. And then where, if that person can't move as much as we need them to, they are either completely lacking physical literacy, they don't understand what they need to do, and we address that first. And if they understand but are incapable, then they were likely hypomobile, which means they're too stable. However, if they can move too much in that range of motion, often that joints, people are considered being double jointed. Right. That's considered hypermobility, and then we need to focus on stabilizing that joint. Your spine or your vertebral column can go through a little bit of lateral based motion, and each vertebrae can do this to a certain degree or another. but your spine, and it can even rotate as well, but your spine's primary motion is flexion and extension. Most of our athletic movements start and begin and are coordinated with our thoracic spine, so the 12 vertebrae that are connected to your rib cage. Your cervical spine we use primarily for awareness, so we can actually see things and move to react to things. And our lumbar spine is primarily for stability. So if you lack stability, which a lot of people do in their lumbar spine, typically is indicative of many of the lower back predominant issues, right? Non-specific low back pain that people have. Right. But usually it's only there for stability. So we need to make sure it's mobile enough, but we don't need to focus on hypermobility of the lumbar spine. Your sternoclavicular joint, which you can see, and I'm articulating that for a reason to help you kind of see where the name comes from. Your sternoclavicular joint is the connection of your sternum and your clavicle. That is actually the only joint that keeps your arm on your body, because your humerus sits outside of your shoulder girdle, whereas in your hip socket, you'll notice that your femur connects to your acetabellum, right? It actually sits within, which is why it's the second most mobile joint on your body. And your shoulders are the most mobile joint on your body because they sit outside of that overall girdle. Yes, well, it's very easy to injure. Oh, you're talking about for hip?
Yeah,
For more neck stress injuries.
I remember him saying
separation.
Oh, yeah. Yeah, breaking the clavicle can be a significant injury.
Right.
And you can see not only because it's the only thing that connects the arm to the body, but all the movements that it does.
Right.
Now, these joint actions are the same as the ones we've been discussing, but they have their own special names, similar to how the ankles flexion extension are plantar flexion and dorsiflexion. For the sternoclavicular joint, it's elevation of the shoulder or depression of the shoulder, which would be up and down.
Right.
And then you have protraction and retraction of the shoulder, which is you with your arms going forward or your arms coming back. Think about doing if you're on a chest press and you push your shoulders forward, even though your elbow's fully extended, that would be protraction. Or if you're doing a row and you're trying to pull the shoulder blades to touch, that would be retraction. The shoulder joint, as we were just discussing, your humerus actually sits outside of the joint on your body, which is what makes it extremely mobile and even more at a risk for injury. But it can still go through all three planes of motion, similar to your hip. Then we have the elbow joint, which only moves in what plane of motion, based on what you see here.
Extension and flexion.
Yes, that you have this joint action is correct, but what plane of motion does extension and flexion occur in?
I'm confused with terminology, man.
It's all right. That's why these are learning opportunities. Don't be afraid to be wrong. You got Sergeant Watts. What plane of motion do the two joint actions of extension and flexion occur in?
Frontal.
So that was 33% guess. You have 66% chance to get it right now.
What you said? It's all right.
I said that was 30. You had you had a 33% chance to get it right, and you were incorrect. So now you have approximately 66% chance to get it right now.
You said what plane, right?
Yeah, what plane of motion does flexion and extension happen in?
All right, yeah, I'm lost.
All right, it is well, let's talk about this. What are your three planes of motion?
That's what I'm trying to remember.
Frontal, sagittal, and transverse.
Oh,
So sagittal, frontal, and transverse.
So sagittal.
Perfect.
Oh, you was talking about
I knew it was starting with that.
Go ahead, Sergeant Watts.
No, I said you threw me off when you said I was like completely wrong. So I thought I was thinking of the whole entire wrong concept. So that's all I was saying.
Oh, I got you. I got you.
Sagittal, but I just said frontal because extension.
Well, it's good. I mean, we don't use these terminologies colloquially, right, in normal dialogue, so they're going to be unfamiliar until we get used to them. But flexion extension only happen in the sagittal plane. Therefore, regardless of the rotation you put your humerus in, right, whether you internally rotate your humerus or externally rotate your humerus, whenever you move your elbow, it's always going through the sagittal plane. And whenever you see only two joint actions like that, typically we want to work on stability of that joint more so than mobility, unless there's been some type of prior injury or restriction. The radial ulnar joint, right, because the two bones that make up your forearm are your radius and your ulna. Your radial ulnar joint is actually what rotates your palm. So pronation is when your palms are facing down, similar to when you're in a prone position for firing and your belly is on the ground. And supination is when your palm is up toward the ceiling or the sky, similar to if you were in a supinated position laying on your back, right? But that occurs right next to or proximally to the elbow, is where that joint actually lies, and that's where all of the rotation happens. Rotation doesn't occur at all within the wrist itself. So if you're thinking about like a front squat position or more prevalent in our population, individuals that have a restriction of being in a good extension position in a front leaning rest position or a push-up, they feel that restriction within their wrist or within their forearm of being able to stay in the extension position. Typically, it's not the wrist that's the issue. It's the lack of the radial ulnar joint being able to go through the pronation while in extension. All right, so that's generally what we need to be able to work at, is working that radial ulnar joint and for pronation and supination. And this is done with one-sided weights. If you've ever been into a gym where you see a dumbbell that only has a weight on one side,
Right.
those are made for working pronation and supination. You can actually use a hammer, if you have a hammer at your house or within your motor pool, for this as well, or a wrench, because it is imbalanced weight. Exactly. So it's an asymmetrical weight, and so you can change, especially with a wrench, because of the lever length of that, you can make it easier or harder by increasing that lever length or changing the length of that lever for pronation and supination to work that range of motion. Good. And then your wrist goes through flexion, which is you taking your fingers and trying to touch your forearm. An extension, which is the opposite, same as we just discussed. If you're in a push-up position, your wrist is an extension. And then it goes through adduction and abduction, even though through most forms of literature and in textbook, you'll see this called radial or ulnar deviation, right? So if you're going away from your radius or away from your ulna, that's that lateral-based movement within the wrist. Now, that's not something we generally focus on in training. That's more of a occupational therapy thing when something is missing, but it's still something I feel that is important to be aware of as a
Right,
trainer.
'cause I know some people, I would say, people have like tendonitis or something.
Yes. Yeah, so without turning this into an HPYP class, when you hear itis as a suffix to a word, that it basically means inflammation. So when someone has arthritis or tendonitis, it's telling you that they have a chronic or constant inflammation within the area. Now, these things can be degenerative disorders based off of biological age and genetic disposition, and prior static and dynamic postures they've gone through. Most people feel that they can't recover from these conditions.
Yeah, you can recover from it.
You can, yes, you can. You
Major
can absolutely.
is surgery.
Potentially.
Potentially, but the therapy, the physical therapy part.
Yes.
Because I had it once I got from basic training, I guess the motion of carrying my weapon like this.
Yeah.
And having my hand like this, it never went through that range of motion before, so it created like to the point where I couldn't move the joint.
Yes, which is if you have sharp pain trying to move your thumb, it's usually called de Quervain syndrome, and there's different ways to do that. But here's an interesting thing, and I'm going to use this as a just to kind of introduce the topic, and we'll mention this more in the next injury class that we have. But one of the big things we need to help our soldiers understand with regards to injuries and medical imagery is that there is no baseline within our healthcare system of what our body looks like, what our specific body looks like. So we have to use basic terminology and understanding of the bell curve with the population. So in other words, if you get an X-ray or an MRI and the physician tells you that you have arthritis, or you have a bulging disc, a slipped disc, a degenerative disc, often individuals will hear that early prognosis and eventual diagnosis, and consider that they have a long-term issue that can't be resolved.
Right.
However, they may have never had an X-ray or MRI of that particular area of their body to see what their body looked like prior. They could have been born with their discs in that position. They could have been born and predisposed with a lot of these things, but
Now, because it causes pain, now you discover it.
exactly. But they never experienced the symptoms of pain and discomfort until some type of inciting event, some type of mechanism occurred. And then now they'll correlate that with what the doctor told them, because obviously most individuals don't know enough about their body. And now they suddenly have a permanent profile or long-term issue. But if you, and we've seen this through medical imaging studies, if you took a large population and you give everyone an X-ray and everyone an MRI, about half of the population may exhibit one of these things, and out of those half that exhibit one of these observations, half of those may or may not have symptoms of pain or discomfort, and the other half may not. And the other half that look like they have quote unquote normal, right? Some no abnormalities within their spine or their structure, half of those may have experienced pain and half the others don't. There's actually been very few to no consistent literature having any correlation of, these X-rays and MRIs of arthritis and bulging discs and slip discs and degenerative discs with actual pain. Yeah. No correlation whatsoever. But we make the correlation and then people add that to part of their character and then they react accordingly. But all of these things can be recovered from. It just requires first an understanding and then two, consistent and specific rehabilitation. Good. Questions? All right, so with that, we're going to delve back into what we talked about with the fascial pathways on the physiology class. Now that we've talked about athletic joints and we've talked about mobility and stability. So on a practical sense, when you want to mobilize or stabilize your soldiers, and you're going to be primarily doing this in your warm-up, right? So let me break it down this way. The best practice, absolute best practice as a coach or trainer is to initially perform a needs analysis. Right? So some type of assessment. And hopefully you have a SMART goal, whether that's per individual or for your section/squad. You perform some type of needs analysis to see maybe they need to pick up boxes. What is their current form and understanding of picking up that box look like? Right? So how efficient are they of that? How do they need to carry that box or that object? Are they carrying that at their side, in front of them at their hip, in front of them at their chest, in front of them overhead, etc. Once you make that determination, you've essentially performed some type of biomechanical analysis. Then you've already assessed their capabilities. You program for each individual in order to improve upon their weak areas. So if they lack dorsiflexion, their warm-up, that soldier-specific warm-up, should include a lot more isolated dorsiflexion. If someone else has too much dorsiflexion, then they may need to work on stability at the ankle joint. But you first need to be aware of these things, then you need to educate your soldiers so that every single individual's warm-up should be specific to their capabilities and their limitations. Good. And then the way you use these slides as a reference is you see the name of the pathway and the plane of motion it goes through. So if it says sagittal plane, what two joint actions are we looking at? You're visually doing it, or physically doing it, but as you verbalize it.
I know the dorsiflexion
and plantar flexion, that'd be true for the ankle joint, correct? But we're talking about just globally in the body. If I'm talking about your knees, your spine, your shoulder, your hip, your back, and we're talking about sagittal plane, what two joint actions occur?
last slide.
It was.
Watts.
They're deferring to you, Sergeant Watts.
What is it? Extension
That's half.
and flexion.
There you go. So flexion is an extension. So when you're looking at this slide and you see, okay, I need my individual to be able to go through trunk or hip flexion, knee extension, knee flexion, dorsiflexion, plantar flexion. If you want them to be able to focus on balance, these are the areas you would need to be able to work on. So you want to make sure that you can either mobilize or stabilize their dorsal toe extensors, right? So the ability to be able to pick up their big toe, right? As an example, or pick up their toes with their foot flat on the ground. Their anterior tibialis is what does dorsiflexion of the ankle, right? And that's where weakness in that area typically leads to shin splints, which is medial tibial stress syndrome. You have your quadricep group, you have your rectus abdominis, right? Your sternocleidomastoid, which is it sounds, it's the connection between your sternum, your clavicle, and your mastoid process, which is where you chew, right? So all of these muscular pathways affect one another, right? So weakness in your sternocleidomastoid, for an example, your ability to have a good clench of your jaw and the positioning of your actual mandible within your skull, those will affect the rest of these ability to go through flexion extension properly. So we always need to look at the body kind of in a holistic aspect when we're focused on mobilization and stabilization. We showed this slide before with physiology on how this fascial pathway can work in a practical sense. We have someone that needs to throw something, in this case unilaterally. You see that anything within that arrow, that red arrow in that pathway, any restriction from the hip, the knee, etc., can reduce the capability of performing well. So for our soldiers, if we're going to be performing the standing power throw as an example, anything in that sagittal plane, anterior or posterior, that's a limitation, can reduce that throw. It's not just about getting them to throw more. It's about figuring out, do they lack stability in the shoulder joint, as we talked about earlier, to prevent external rotation of the humerus? Can they coordinate the combination of hip and knee extension so that those joints come to full extension simultaneously? Can they go through proper shoulder flexion and, et cetera, in order to be able to do the action properly? Right. This is a sagittal plane on the posterior side, or at least from the superficial, so the muscles that are closer to the surface of the skin. So you see that the way these are broken down for your later reference are the name and the plane of motion. Then you have the pathway of all the muscles that are affected. Then you have the biomechanical functions. So if you need someone to be able to focus on supporting posture, right? We have a lot of military police as an example, and truck drivers. If they feel that in that seated posture, or even finance individuals, human resources, if they're sitting at a desk for a long period of time and their ergonomics of their posture are relatively inefficient, these are the musculatures and the areas we need to focus on mobility or stability in order to help prevent some of those postural deficiencies and then the subsequent pain and discomfort that are typically associated with those deficiencies. Okay. Lateral, right? Remember, our frontal plane helps our sagittal plane motion. If you don't go through hip abduction and adduction with your TFL, your tensor fasciae latae, and your groin muscle group, or your adductors, respectively, then you may have knee instability when running around a track, especially if you always run and turn the same direction. So you see lateral trunk flexion. So a lot of a really good example of this is non-specific low back pain with deadlifts and squats. Right, we'll have soldiers that try and stay away from adding squats and deadlifts to any type of exercise they do, let alone have any type of program, because they regularly experience some type of discomfort or pain in their lumbar area when they do these motions.
So you don't do it enough.
One, they may not do it enough, absolutely. And when it comes to their form, it may be inefficient because they may be able to go through proper flexion extension, but maybe they don't work on lateral movements at the hip or rotation at the hip. Very often individuals may rotate within their femur in one hip versus the other when trying to go through that squat or deadlift pattern, unaware of what they're doing, through a compensation, which prevents them to move through the sagittal plane exercise, because deadlifts and squats are sagittal, properly, and that gives them that risk of injury. Okay. What do you see as the second to last bullet on this slide? Sagittal deceleration, right? So when you're running and you need to slow down, right? Think about doing a 3 to 5 second rush, or you're throwing a 10-pound sphere behind you as far as possible. If you don't work on stabilizing your joints in the frontal plane, you will not be able to optimally decelerate sagittally, which is where a huge incidence of injury may occur. Right? But it's the things that we don't focus on that typically hold us back. This is going to be our transverse plane, so our rotational aspect, everything that helps us not rotate, right? When we're running, when we're biking, we're swimming, we're doing anything, we want to reduce rotation as much as possible. Even here, the second to last bullet is acceleration and deceleration, right? Your ability to produce power. Again, your frontal and transverse plane will affect your sagittal plane, and then so on and so forth. Your deep core chain, right? Your deep frontal line. This is where your true stabilization, especially in your core lifts, comes from. Your ability to actually use your diaphragm to treat your lungs like a bellows and to pull your lungs down through the inspiration in order to increase intra-abdominal pressure and brace your lumbar spine through a heavy lift. Okay. You notice with your recovery gait as well through running, if you don't properly train these mechanics, and this is huge for especially pregnancy and postpartum for the pelvic floor for females, right? When they go through diastasis recti and you have the separation of your linea alba, that line in your rectus abdominis, and especially if they have a cesarean section postpartum, they have torn through their abdominal wall. So if they're not taught how to re-establish stability, they're never going to be able to produce that type of global force to help their vertebrae. And they're again not only lower performance but greater risk of injury. This is true for male and female. Those are just an exaggerated example. They're just an exaggerated example for population. Okay. And then spiral line for the other aspect of transverse. This is where everyone wants to work Russian twists and all these things, but that's almost the exact opposite of what you want these muscles to do, right? You want to be able to prevent rotation. A weakness here in stability is what causes valgus. You see at the where your tensor fascial octave turns into your iliotibial band on the lateral aspect of the patellofemoral joint. That weakness here causes a potential lengthening of this structure, which causes the knee inflection to internally rotate and causes that valgus to occur. And you see that with the patellar tracking aspect. So you want to make sure you can train the musculature of your tibialis anterior and your TFL and things like that in order to prevent those motions from taking place. Okay. All right, so far in our discussion, we've kind of defined mobility and stability. We've discussed how to assess that within our soldiers in a not necessarily a rudimentary sense, but in a global sense, because every single one of us in this room and every single one of our soldiers are going to have very individualized limitations and capabilities, right? Our body is simply a product of our behavior, of our habits. So whatever range of motion you currently have, you have that because you've told your body and taught your body that's important. If you don't take your shoulder through rotation, you're telling your body, do not maintain the capability of rotating my shoulder. And therefore, over time, you lose mobility. You lose rotation. If you don't take your hip through abduction and adduction, you're teaching your body to reduce your capability of abducting and adducting your hip because your body has no moral compass. It doesn't have an objective for your overall goal. It just adapts to exactly what you do in order to maintain what you've told it is important based on consistency. Okay. The colloquial mistake we make with this process is we typically call the reduction of range of motion getting older.
Wow.
We usually attribute a lack of range of motion and capabilities to biological age, when in actuality, it's simply a reduction of actual movement. Yes, absolutely. As we become older and we start thinking, best warrior competitions are for our younger soldiers. PT is for, the enlisted because they have somewhere to grow. I don't need awards. I don't need coins. I don't need promotions, right? I'm a senior enlisted individual. I am the company commander. I am the sergeant major. I am the senior staff individual. these opportunities are for my soldiers, not for me. In a accolade sense, that's true, and I agree. But from a performance sense and for overall quality of life and health, a lot of times individuals don't consider the cascade of effects from the psychological behavior that they're placing or they've established within themselves of this isn't for me. They're not out there performing the inventories anymore. Not that it's beneath them necessarily, but the higher you get in rank and responsibility, the more things you have to do. And therefore, you're not out there reaching above your head often. You're not out there internally and externally rotating each of your joints often, let alone do you know what you're doing. And then typically at an older age, people aren't trying to get the attention of, the opposite or the same biological sex, right? Depending on their preference. And so if they're not out there trying to focus on all of these things, they're teaching their body through not moving to not be able to move. Right, so that's a key piece for both our injury rehabilitation piece and the overall ability to perform. And you typically hear the old idiom of motion is lotion, right? If you want to be able to move, you need to keep moving. So we just need to be able to take that and we need to be able to apply it through an understanding of anatomy and physiology, looking at the actions we're doing, the actions that we need to do, and then concatenating those into a practical motion, which we see with our squad and with our section as even from a first line leader perspective, for our actual physical readiness training sessions, whether individually or as a group, right? So that summarizes this particular clinic time-wise on mobility and stability. I want to be bringing this to a close. We will be having a practical exercise with this coming into the next assessment that we do. So please pay attention to our CTAS SharePoint for any type of changes to our upcoming calendar. But at this time, do I have any lingering questions on content that I've initiated for mobility or stability?
No.
Any questions on your end, Sergeant Watts?
No, I'm all good. All right.
Perfect. All right. So I appreciate each of you being here, and I'll see you next Tuesday at our next clinic.
Cool.